A pleasant good morning to the viewing public. On behalf of the University of Trinidad and Tobago, or UTT, I would like to welcome you to another session of an ongoing UTT-promoted webinar series geared at educating the public on different topics of interest that our various units have found worth addressing. Considering the worldwide interest and focus on the novel coronavirus, the Biomedical Engineering Unit of UTT has seen it fit to host this live webinar coexisting with COVID-19 that looks at the pandemic in a holistic manner. Due to a curative vaccine not presently being available and the current drive toward regaining acceptable normalcy in our country's activities, inclusive of reopening our country's borders, this webinar aims to educate you, the public, on how to effectively deal with the various situations that may have arisen or yet to arise from its effects. Joining me today is a panel of highly qualified and prominent epidemiologists that we are grateful to have taken time from their busy schedules to be part of this event. Let me start by first introducing Dr. Avery Hines.
Good morning, and thank you for having me.
Welcome, Dr. Hines. Within recent months, Avery has become a local celebrity, being a featured consultant, in the public briefings on the local spread of COVID-19. Dr. Hines is a medical professional and leader with a strong background in public health, intergovernmental program management, academic development, and public sector relations. Next, we have Dr. Hamish Mohammed, who is joining us from London.
Morning, everyone. Thanks for having me.
Welcome, Hamish. Hamish is a consultant epidemiologist and national lead of sexually transmitted infection surveillance at Public Health England, or the PHE, and is one of the epidemiologists responding to COVID-19 there. I should add that the views he expresses are his own and do not represent that of the PHE or the UK government. And last, but definitely not least, we have Dr. Eldona Boisseau.
Good morning to all. Thanks for having me.
Welcome, Eldona. Eldona has worked with the Pan American Health Organization, PAHO, or WHO, for over 20 years as an epidemiologist serving the Caribbean. Currently, she is one of the members on the PAHO WHO Regional Incident Management System team for COVID-19, working in the areas of public health measures and surveillance. Now, let me introduce the members of our UTT team. I have the pleasure of introducing our first moderator, Dr. Amalia Hussein, an assistant professor at UTT.
Good morning.
Welcome, Amalia. Thanks for your assistance. Dr. Hussein has a PhD in biomedical engineering, and her research focuses on the distribution of genetic markers of non-communicable diseases in multi-ethnic populations. Next, I have the pleasure of introducing our second moderator, Dr. Ashton Rogers.
Good morning, everyone. Thank you for joining.
Welcome, Ashton. Ashton will be assisting Amalia in the tremendous task of moderating the session. He holds a PhD in neuroscience and is also an assistant professor at UTT. His research focuses on elucidating the effect of diet in neuroinflammatory diseases, such as Parkinson's disease. And finally, yours truly, Dr. Varma Rambaran. I hold a PhD in inorganic chemistry, and I'm also an assistant professor in the BME unit. My current research focuses on the development of a family of novel or orally administrable drugs for type 2 diabetes therapy. So, at this point, I would like to hand over the stage to Dr. Amalia Hussein, and I urge you, our viewing public, to sit back and enjoy this very informative and exciting discussion on how to coexist with the COVID-19 virus. As we are streaming live, please feel free to send in your questions on YouTube or Facebook. And our research assistant, Ms. Nalini Singh, and program officer, Ms. Karen Marique, are presently with all electronic sources awaiting your questions for the panel. Amalia, the stage is yours.
Thank you very much, Dr. Rambaran. A special welcome to our panel of experts and to our live viewers. And thank you very much for reaccommodating us after our canceled session on Wednesday. This is a question and answer webinar, and we invite you to post your questions in the chat that is available. We will now take our first question from Dr. Rogers and to our panelists.
Good morning, everyone, and thank you for joining us. Let's get straight into it. This webinar is very timely because the world just experienced the 6-month anniversary of living with COVID-19. And this pandemic, of course, is ongoing and increasingly becoming worse. In order to understand the present and to look into the future as well, we sometimes need to look at the numbers in the past. Going back a bit, we had the Zika flavivirus, which emerged in 2015 with an accelerated geographical spread. We also had the West African Ebola outbreak in 2014, the Asian influenza H2N2 pandemic in 1957, and of course, we must also mention the H1N1 swine flu pandemic in 2009. In the last 2 decades, the world also witnessed the emergence of 2 zoonotic, highly pathogenic human coronaviruses, which are severely acute respiratory syndrome SARS coronavirus and the Middle East respiratory syndrome MERS coronavirus in 2012. So, panelists, from these previous outbreaks, are there any lessons or models that can be applied to the present understanding of the epidemiology of COVID-19?
So I'm happy to kick things off. And Dr. Rogers, I think you hit the nail on the head. So there are 3 things that immediately come to mind when we think about the experience we as a people have encountered in terms of the pandemics in the past. And to that list, I would add the 1918 Spanish influenza pandemic. And some would argue the chikungunya outbreak of a few years ago also was a pandemic. So the 3 things are as follows. One is the dramatic and rapid spread geographically, and the extensive disruption to daily life and degree of anxiety that these pandemics cause for a variety of reasons. So we all remember with Zika virus that there was an increased risk of, birth abnormalities. And again, that's a really severe complication due to Zika. So again, that's the first thing. And in terms of mitigating against that, we would certainly look to adhering to public health advice to manage that as best as possible. The second is the detrimental effect of misinformation, which is further galvanized due to the ubiquity of social media. So in this day and age, we all know how much the role social media plays in day-to-day life and in sharing news. So it's important that we get information from official sources. The third thing that I would say that we'd learned from the previous pandemics is how crucial collaboration is. When I say collaboration, I mean public-private sector within and between governments, because it is through collaboration, sharing information rapidly, and learning from best practice that we could go about handling these.
So if I can pick up from there on that point of collaboration, I think that is a major one, not only amongst countries, but also within the country. Certainly we've seen in the past, and it's been highlighted in this current pandemic, the need for a whole of government approach. Even though these things that we're speaking about, the diseases, are health conditions, it is not health on its own that can tackle it. So a whole of government approach is essential. In terms of mitigating against these diseases, what we've been seeing for all of them is the need for strong disease surveillance systems that can quickly detect what is occurring. This has to be accompanied by strong laboratory systems, or sometimes in our small countries in the Caribbean, at least access to a laboratory, so you know what you're dealing with and you can monitor well. And by doing so, as you quickly identify cases, you can take mitigation measures, be that isolation, if it's something you have a vaccine for, vaccination, if you have to do contact tracing. And in fact, that's what we're learning. We've seen it in the past, and we're getting a refresher with this pandemic that has to be done very, very quickly. The other thing that I think is highlighted a lot now is that need for communication, risk communication, and engagement, community engagement, because all the health measures and public health measures that we have to put in place, if we do not have community engagement, it doesn't work. So community engagement is very important. And I think this pandemic in particular is showing us the challenges as we compete with social media, because social media doesn't have any rules and regulations, and it moves at lightning speed. In health, we have a lot of rules and regulations as to how we transmit data, and the speed, we just cannot compete. So this is really a learning experience for us.
Dr.
If I
Hines,
may
would
just
you like to
tag
make a
on,
comment?
sure, just to tag on to the comments made by my colleagues, with which I concur fully. I think the other thing that we saw in each of those was the role of the mobility of human populations in terms of facilitating spread. We saw the role of the mobility of human populations in facilitating the spread of Zika and chikungunya. Although that was a vector-borne thing, the people that had it had to move to where the new vectors were. And the movement of those persons from one place to another was actually basically mirrored by the international travel patterns. The fact that the Ebola outbreak, which was more a contact and a body fluid related mode of transmission, remained where it was largely was because of the mode of transmission and the level of mobility within the populations there. And we are seeing with anything respiratory that, as with H1N1 in 2009, and as we're seeing now with the coronavirus pandemic of 2019 to 20, the role of international travel and the speed with which both persons and pathogens can transcend international boundaries, that is something that is not to be ignored. And it emphasizes the importance of the systems that Dr. Boisson just outlined in such useful detail. So I think that we're in a good place to have useful conversations on how all of these things intersect in moving forward, and in, as we've titled this, living with or coexisting with COVID-19.
Thank you very much. This is a question for all the panelists again. Can you tell us or give us an update on the numbers in your region from an epidemiological point of view? For example, things like new cases, mortality rates, recovery rates, and what changes you guys are seeing?
So I'm happy to kick off this component again. So in the UK, what we're seeing, we've seen a total of just under 300,000 cases of COVID-19, and of those, about 45,000 have unfortunately died due to COVID-19. So what we saw in the UK was a rapid acceleration of cases over the months of February and March, so a genuine exponential spread as we witnessed community transmission. So in other words, more widespread transmission amongst members of the general population. Strict social distancing measures were introduced on March 23rd, after which there was a peak in the number of cases, and it has been falling steadily. So what we're seeing here in the UK is a long tail. We've had a first peak. There's been evidence of a clear wave, but now there's a long tail of that outbreak, such that we're seeing 500 to 600 cases every day and about 50 to 100 deaths every day due to COVID-19 as well. The other thing that's changed here is that as social distancing measures have had a demonstrable effect in terms of reducing the number of new cases, what we're seeing now, and this is happening in a lot of high-income countries as well, is confined outbreaks in certain occupational settings. So meat factories, poultry factories, and so on. So that's the epidemiology of COVID-19 has changed. And Dr. Rogers is right in terms of it's just been 6 months, but there's been a really changing pattern in terms of the epidemiology of COVID-19.
So I'll bring it now closer to home before Dr. Hines zeroes in on Trinidad and Tobago, and I can speak of the region of the Americas overall. So we've had over 7 million cases already in the Americas, and as you probably have heard, the Americas is currently the epicenter of this outbreak, this pandemic at this point in time. So far, about half of these, a little over 3 million, have already recovered. We've had close to 300,000 deaths, unfortunately. The case fatality rates, it varies very widely. So for example, in the US, where they have had over 3 million cases, their case fatality rate is just under 4%. As compared to Mexico, where they've had about 300,000 cases, their case fatality rate has been 11%. Canada, surprisingly, with only just over 100,000 cases, has a case fatality rate of 8%. So the case fatality rate, it depends on a lot of things that are very variable amongst the countries in the region. It depends on the age structure. If you have an older age structure, it depends on how many vulnerable persons you have. It depends on your healthcare system and how you can treat with cases. So not because you have more cases do you necessarily have a higher case fatality rate. The other thing that we see varying very widely through the region is the transmission type. We have countries in North America, the US and Canada, and most in South America is having widespread community transmission, which means it's in there and it's spreading around. In the Caribbean, we have few countries with community transmission. I guess Haiti would probably be one of our closest ones. Most of our Caribbean countries actually stepped in very early in their outbreak, put prevention and control measures in place, and so very quickly now got it under relative control, and currently now have imported cases as people are starting to open borders, repatriate nationals. In some places, they have a little bit of sporadic spread. So the Caribbean is in a pretty good place. We've had a first wave, while globally we're still in the first wave, because if we were to look at number of cases going up worldwide and we track that on a daily basis, it's still going up. It hasn't started to go down. But if we look in the Caribbean, all our countries, or most of our countries, I should say, have had a first peak like Trinidad has and gone down. We're now starting to get some spattering of cases as persons come in. Do we expect to see another resurgence as persons coming? Possibly. What we definitely will expect to see is imported cases. How we treat with those would tell us how many we get spreading. And certainly, if I might just say, once we open borders, which of course for economic reasons, at some point, all countries have to, there is absolutely nothing that any country can do to reduce the risk to zero of imported cases. They can reduce that risk, try to mitigate against it, but there is nothing they can do to make the risk of importation zero once COVID is still out there. So I'll hand over to Dr. Hines to maybe give a more local Trinidad and Tobago perspective.
Okay, thank you, Dr. Boisson. The epidemiology of the pandemic in Trinidad, I think we've been updating that with the national public on a daily basis. And the number of cases at the last update that I have seen that I'm aware of was 133. Of those, as Aldana quite rightly described, the first wave, although it was not a wave of community transmission, the first wave of persons that were detected with COVID-19 occurred between the middle of March, just about, and the end of April. And most of those cases were in persons who had come in from international travel, had been mandated to quarantine, had identified a respiratory illness in themselves, and had been swabbed. Now, that process of coming in, quarantining, identifying respiratory illness, and getting swabbed was something that was very actively supported by both the national systems and the international systems that promoted access to the testing materials, to the PCR, while we developed local capacity. So there was a lot of international collaboration in making sure that happened. As we would be aware, we did have one interesting event of an international conveyance, a cruise ship, that brought in a big group of people. And of that group of persons, more than 2/3 of them actually then turned out to be COVID-19 positive because there was spread on the cruise ship. And we've seen that in other international settings as well. There was the Diamond Princess setting of a cruise ship off of Japan, lots of cases. So we saw again the role of international travel and the role of certain settings, cruise ships in particular, in being sort of facilitators of spread and also imposing risks to populations. As we are aware, the Caribbean, including Trinidad, implemented a lot of very strict public health measures early on in the course of the introduction of the virus, and those public health measures would have served to reduce the potential for spread within the community to the extent that Trinidad did not have community spread. We found imported cases, and when the time frame within which imported cases would no longer manifest, when that time frame was up, there was no additional respiratory illness activity in the population that indicated that there was something else going on, that there was additional respiratory transmission within the general population. A lot of surveillance took place to ensure that we're not missing anything. A lot of what we call community-based surveillance, anybody with any respiratory illness being offered swabbing to ensure that we're not missing cases within the population. And to date, with over 2,000 of those samples having been performed, we have not seen any cases of COVID-19 within the population. What we have seen is that as we repatriate additional persons, we have found that quite a few of those have come back being COVID-19 positive. So our first wave took us to 116, and then the others that took us from 116 to 133 have all been repatriated persons from different settings. And that is what we expect to continue to see. It's the reason that there's a lot of care being taken around how border opening would be managed. And it is the pattern that any country that is opening borders and bringing persons in is going to be expecting to experience. So again, endorsing what Dr. Boisson said, once there's border opening, then there's going to be a continued risk which you can mitigate but not eliminate. Last but not least, with regard to the case fatality rate, with our numbers, what we had was 8 fatalities out of the now 133 cases that we have identified, which gives us a case fatality rate of around 6%. But I think it's sometimes a little bit misleading to look at case fatality rates in settings where there wasn't actual transmission throughout the community, because if it's imported and sporadic cases, it kind of depends on who got sick. So if we had a lot of ill people that were in the older age groups and in the more high-risk age groups because of coexisting conditions, etc., then we may have had more persons that died. And if we had fewer of those, we may have had fewer persons that died. So again, case fatality rate has its limits with regard to how you use it to interpret the severity of an outbreak in a given population. Okay, over to the moderators.
If I could just come in on that point. So both Dr. Hines and Dr. Boisson alluded to this. So there are a number of challenges when we try to make international comparisons based on case fatality rate or deaths due to COVID-19 for the reasons already outlined. So I would encourage the viewing public to bear that in mind when they're seeing. The media will make these comparisons. They will take the publicly available information and derive the rates of death. But again, just to reiterate, the case fatality rate is subject to a number of changes. It depends on the individuals that were infected with COVID-19. It also is heavily reliant upon the testing policies within different countries. So what you'd find is in certain countries, there may be more diagnoses because there's more comprehensive community testing, for instance. The other thing is where there are, Dr. Boisson alluded to this, there are different age structures, so different regions of the world, different countries may be more or less likely to have younger or older populations. That will also impact on the case fatality rate and the overall mortality rates. So it's just something to bear in mind that every circumstance is unique, and there are innate challenges to making these international comparisons.
Okay, thank you very much, Dr. Mohammed. Dr. Rogers, we'll take our next question. Very interesting perspective.
Thank you very much for those brilliant and very important points. And I'm sure that our viewing members are appreciating all this information in a very concise and precise manner. So thank you very much. Before we leave this topic of international travel, though, I'd like to sort of discuss it a little bit further. We are seeing that other countries in the Caribbean are opening up their borders, and they have implemented one regulation, which is you must present a certificate indicating that you are COVID-19 negative in order to enter a country. So it's a two-part question. Do you think that Trinidad and Tobago will open its borders soon? And if we do open it, do you think that a certificate indicating that a person is COVID-19 negative will be sufficient, or should we do even more as we are in such a good position?
I'll kick off with the second part of that question. I'll leave the first part to Dr. Hines because he works with the ministry and be better able to answer. But in terms of the testing, right now, there is no foolproof test. The real-time PCR, which is the approved and recommended test that is reliable, in the first 1 to 3 days of infection, when the virus has not multiplied enough, you can be infected and have a negative test. There are rapid tests that look for the antigens on the surface of the virus, and there are tests that look for the antibodies, the body's reaction to the virus. We currently have no tests globally of those rapid tests that are reliable. They're not sensitive enough. They give false negatives and false positives. We're looking forward to getting such tests that are reliable, and there's a lot of research going on. But at this time, none are reliable. In addition to which, when we do get one that that measures your body's reaction, all it tells you is if you have had the disease in the past. It does not tell you how long your immunity lasts. So just because you've had it before, it doesn't mean that you cannot get infected again. So there is a heavy reliance on testing, not just in the Caribbean, but globally. But in all honesty, heavy reliance on testing gives a very false sense of security. Because if I test negative today, it just means that I am negative at the time they took my swab. I can be negative now and test positive tonight or tomorrow. So I come through and I'm negative, and I go out into the community and I can be positive. It gives a false sense of security. It's also very resource intensive. And a couple of the countries in the Caribbean who've been doing that have been analyzing what they've been doing, not just testing, but other measures as well. And they have quickly recognized that the massive testing is absolutely not sustainable. And it has really not borne much fruit. They're not finding people coming in testing positive, because globally, the ill people, persons who have tested positive, are not allowed to travel. Where they have had imported cases and they detect them are when they're in the country and they become ill and seek healthcare. So it's very important that countries, and I'm sure Dr. Hines will be able to tell you, Trinidad and Tobago is aware of that, the countries make sure when they are opening borders that they have the capacity in country to monitor their visitors, to have that community engagement, to let visitors know what they want them to do in terms of prevention and control measures, what they want them to do should they become ill, so that there's a focus on quickly detecting people if they become ill, isolating, treating, quickly finding contacts, quarantining the contacts. The other thing that countries would want to do, rather than massive testing, is to really open borders based on some key factors. First of all, the capacity they have in country. What capacity do you have for providing care for persons who become sick, for doing your public health measures of contact tracing, surveillance, and so forth, and make sure that you don't overwhelm those. You also want to have ongoing assessment of what's happening out there in terms of the countries and conveyances that you allow persons to come from. So if you know that your capacity can only handle X amount, and you cannot risk bringing people from high-risk areas, you have to monitor. Remember, it's changing everywhere. You have to monitor, and maybe you make decisions that you're going to let persons in from some countries, not others, some states, not others, so forth. And the Caribbean is doing that. I know they're doing that in Europe as well. And thirdly, the community engagement, because whatever measures you put in place for that quick detection, it means that your travelers coming in, your community have to be on board with that. And so it makes more sense to target your resources. The evidence shows it makes more sense to target your resources in country, have those prevention and control measures in place that we already have, the hand washing and physical distancing and don't touch your face and use your mask when appropriate, all those different things, that your visitors do that and so forth. Most persons are, in fact, the outbreak is driven really by symptomatic people. There have been cases of asymptomatic persons spreading, but it's driven by symptomatic people, just because when you're asymptomatic, the virus hasn't built up yet. So if you're asymptomatic, you're not coughing and sneezing, you use the right public health measures, you're much less of a threat than someone symptomatic. And if at that point that you become symptomatic, you know what to do, or the people around you know what to tell you to do, and you isolate right away, you have very minimal risk to those around you. So maybe that's a little bit more than focusing on the lab, but giving some rationale as to why we should not be lulled into a false sense of security with laboratory testing. So over to Dr. Hines.
Thank you, Eldona. I could not agree more with everything that you pointed out with regard to the role and the place and the value of testing in the wider context of how we open borders and how we manage the risk, the global risk of importation going forward, because the global risk of importation is going to persist for quite some time. We're quite aware of that. And because we know that any change in the current international travel policy needs to take into account this protracted risk of importation. There is a place, yes, for the use of tests, but we cannot, even with the mandating of a negative test before you come in, we cannot guarantee that someone who tested negative, especially if we're asking for a test 72 hours, 5 days, etc., prior to travel, and especially because the practicality of getting a test just before you travel is minimal. You're going to need to try to get that test done and get the results back a couple of days before you move. So the utility there is that if somebody was positive and they didn't know they were positive, they then detected at that point and they don't travel. This would really then sort of filter out asymptomatic positives, because the symptomatic people are not supposed to be trying to travel in the first place, and no one with respiratory illness is supposed to be allowed to travel. So it's a multi-layered approach where filtering out symptomatic people to start with would be the first layer of protection for international travel. Perhaps using the testing, and it's still debatable, perhaps using the testing to filter out asymptomatic positives is another layer. But even more important is the ability to ensure that if someone becomes positive when they enter your population, that they are not in a place or in a position or in a setting where they can then transmit rapidly to other persons. And herein lies the need for the quarantine of anybody who's coming in from a country where there is transmission. And that quarantine restriction then needs to be monitored. And the monitoring requires that you have the capacity to actually follow up with all the persons who have come in such a way that if they become symptomatic, they can be tested, or in such a way that they can be tested at the end of the quarantine period to see if they have converted from not positive to positive. So there's a lot of dynamic monitoring that needs to happen. The community engagement, the communication with persons coming in to let them know the importance of being honest and of sharing information readily and quickly. That can't be overemphasized. You can't overplay that. It's necessary. There's no way of exaggerating how important that is. We really do need to ensure that people who come in are in the right headspace where they actually recognize the importance of disclosing early if they have symptoms, if they don't feel well, as opposed to trying to evade the inconvenience of testing positive and having to go through the health system. Another thing that is of importance locally, and that Dr. Wassau alluded to, is there's only so much health system capacity to manage persons who are A, being quarantined, or B, who are not positive. And any decisions that you make will have to bear in mind your capacity moving throughout the time frame that we are risking international importation, we have to be aware of when we are in danger of exceeding or breaching the limits of that capacity, so that additional measures to reduce spread may need to be implemented. So with all that in mind, while I'm not in a position to say whether borders will be opening soon or not soon, what I can say is that there is intersectoral, interministerial collaboration, and not just interministerial, but interdisciplinary, including the aviation sector, including the tourism sector, ensuring that all of the necessary preparations are being put in place at this point in time to facilitate all of the monitoring, the engagement, the management of persons coming in, so that whenever the borders do open, we are in a position to mitigate that inevitable risk of importation of COVID-19. Over to the moderators.
Thank you very much, Dr. Avery. We have our next question here, and briefly, if we can talk about masks. We know that masks have been advised to be worn, and we recognize that surgical and N95 are really for the healthcare workers. For the general public, it is advised that medical or cloth masks be worn. Can you tell us what is an effective cloth mask? We're assuming here that not all cloth masks are equal. And if you guys could give the public some idea of what they should be looking for when wearing a cloth mask and what kind of precautions to take.
So again, I'm happy to start with this, but bearing in mind that there is a degree of heterogeneity as to the guidelines around face coverings by members of the community. So in terms, the WHO has published guidelines, but the key thing to bear in mind is that masks shouldn't confer a false sense of security, and they should not be used instead of adhering to social distancing guidelines. So again, maintaining distance from people who are not within your household, also ensuring you practice good hand hygiene, you cover your mouth and your nose when you cough and sneeze. But to go directly to Dr. Hossein's question, some of the principles, again, is to ensure you're taking them on and off correctly. You're not putting them on the top of your head, below your chin. You're not touching them, contaminating them. And you ensure that you wash your hands before and after removing the mask. What you'll see is when the UK, a combination of 2 different types of fabric is recommended. But again, that guideline is slightly variable from one country to the next. And this is, I'm making a distinction deliberately here between face coverings and medical grade face masks, because face masks and medical professionals are trained and fit tested to use those N95 masks, and they know how to use them in a particular setting. For those of us that don't work regularly in medical settings, it's a novelty. It'll take some getting used to, but the objective of the face covering is to protect others from potential spread of the virus if someone is asymptomatic. So it's really about a gross barrier. And when I say gross, I don't mean just an actual barrier just to confer some protection against respiratory droplets.
Okay, thanks. That seems very useful. I just wanted to know, for Trinidad, though, Dr. Hines, is it that we have any kind of criteria for the face mask? Like, do you want like 2 layers, 1 layer? I see people using bandanas. Can you give us like just some idea of what is allowed and what really is considered? Do we use a crochet cloth? Those kinds of things.
Okay, so for Trinidad, I know that they had initially put out some specific sort of criteria guidelines, some actually a pattern with regard to how masks could be put together, and it was at least a 2-layer, if not 3, but at least a 2-layer piece of face covering that would reduce the risk for expulsion of droplets. Now, the rigidity with which people have been asked to stick to that particular sewing code, for want of a better word, that has been not so actively followed. It's not been so actively enforced, because what we really do want to ensure is that some form of face covering is utilized by everyone. And to the extent that face coverings are utilized, there is some level of reduction of risk of the droplet transmission. The masks that were distributed, I did not actually see what those looked like, but I know that those sort of follow at least a 2-layer construction. I've seen people wearing masks made of apparently denim, I'm not sure that's a great idea in terms of breathing, but there's been a lot of variety in the masks that you see people utilizing. Crochet, I had an actual and an interesting experience. I saw someone wearing what appeared to be a crochet mask, and I was horrified because obviously crochet, the spaces they hold are way too big. But I was reliably informed that a lot of the crochet outsides are lined by something inside. Now, we're hoping that there are at least 2 layers inside and the crochet is a decoration. But the important thing beyond what it's made of is how it's actually worn. And we want to make sure that people know that they need to cover both their nose and their mouth at all times that they're wearing the mask. People pulling the mask down below their nose is defeating the purpose. Taking the mask off so you can speak and be heard is also defeating the purpose. So proper use of whichever face covering you're using is probably even more important than how well constructed the face covering is. And as Dr. Mohammed pointed out, the hygiene around it, the hand washing, the not touching it while you're wearing it, etc. Those are all important, quote unquote, layers to the actual effectiveness of the mask.
If I may add to that, WHO guidelines is actually 3 layers. Cloth masks, this is the first time cloth masks are really being employed. And the recommendation is 3 layers, breathable fabric on either side, and something lighter filtering fabric in between. The recommendation from WHO is also to use masks where you have community spread and you are not able to physical distance. Now, I know Trinidad and Tobago does not have community spread, but the ministry is advocating for use of masks in public spaces where you cannot distance, which means they're veering on the side of caution. The WHO recommendation is exactly that. Every country has to take that recommendation and apply it to their own context. In the Caribbean, most of our countries are an island, which means that we have inordinate number of borders, and even those that are mainland, like Guyana, Suriname, they have land borders as well, which are not all manned, obviously. And so every country has to take our advice and adapt it to their context. We also in the Caribbean looking to open borders. Some have already opened borders. And so it may well be that countries are trying, even though they don't have community transmission, to get persons accustomed to what they should be doing in the event of. So I want to emphasize though, that hygiene, if you are using a mask, in addition to washing your hands before you take off and put it on and using it right, that inside of the mask that touches your face, you need to get into the habit of not having anything touch that, including your hands. You want to make sure if you take that mask off, that whether you fold it in half and put it in a bag, put it in an envelope, because if you are touching the inside, or you throw it down in the car and it's touching the parts of somewhere in the car, and then somebody touches it and contaminates, then you're taking that directly contaminated mask and slapping it straight onto your nose and mouth. So you want to be very careful, and a good thing with cloth masks is that they can be washed. You want to be very careful once your mask gets damp, once it's dirty, or once you touch that inside or anything else touches that inside, do not put it on your face again, and do not share masks either. So I just wanted to add that little bit.
Okay, thank you very much, Dr. Bossa. Dr. Rogers, we want to take a question from our chat that's coming in live from our viewers.
Certainly. Dr. Bossa, I couldn't agree more, and thank you so much for brilliantly explaining the way to properly use a mask. This question is coming in from Diego Martin, and this person would like to know, what can the authorities do to get the general public to actually follow these guidelines that have been outlined by CDC and WHO? Because we are currently seeing people in the public, not wearing masks and not following our guidelines of social distancing. There's also a bit of hype on social media that masks are not actually helping. What can we do?
I can start. I mean, it's really about community engagement. I think our governments have been doing a very good job. Updates almost on a daily basis. Information accessible in all different forms and fashions. So a lot of community engagement. The fact of the matter is people are people. If we compare what's happening in the Caribbean to what's happening in some other places, I would say we're seeing a much higher level of compliance here. People are people. There's a package of prevention measures that are out there. It's not just face masks. It's not just physical distancing. It's not just hand washing. It's all of them. And so I think we have to look at the individual situations. So it might be that some persons who are not wearing a face mask are physical distancing, or someone who are not physical distancing are wearing a face mask. You need to look at the package of prevention measures and try to get through and to get people to understand why it is they need to do what they have to do. Understanding people are people, and there will always be some who will not do what they're going to do. So short of some sort of penalty, and again, you have to weigh up, I think the minister has said this, you have to weigh up when you are trying to win the battle and lose the war kind of thing. Are you going to jail everybody who doesn't wear a mask? You're going to run out of jail space. So there has to be this community engagement. And I do think not just Trinidad and Tobago, certainly Trinidad and Tobago, but the Caribbean is doing a really good job with that. And when I look at the response, it really has been pretty good in most instances. Some things are fairly easy for us. The hand washing, we grow up with that. Our parents tell us that all the time. Cleanliness is next to godliness. Wash your hands before this, wash your hands after that. So the hand washing is not such a big stretch for us. Physical distancing may be a little bit more difficult because culturally we're more interactive people. But even that, I do see compliance, not everywhere, but there is compliance. The use of mask, some people are using it as a fashion statement. So yes, you see some crochet stuff on the outside. Again, that's part of community engagement, empowerment of people, that you can feel that you are doing something. Maybe it's more than it's required at this time, but it's practice. It's practice for when we open borders, for if we have spread, for when you decide to travel later on, so that you start practicing doing the right thing from now. So other than being heavy-handed and having penalties, you can't guarantee that everybody's going to do what they're going to do. And even with penalties, otherwise we wouldn't have any people in jail, right? So it's a matter of discussion, getting people to understand, engagement. I don't know if any of the others would like to add.
I think I can.
Okay, go ahead.
Go ahead, Dr. Hines.
Okay, I said I'd like to again endorse all of that and to say that part of getting more engagement, more people to follow the correct patterns is normalizing the good behavior. So the more people utilize the masks as part of their daily routine, like for example, I've started getting matching masks. The mask matches what I'm wearing. I have a friend who actually makes these. That is a way of making it part of your daily routine. You put that information out there, you show, you lead by example. The other thing that we have done in terms of, for want of a better word, enforcing or encouraging mask use, especially where it's most important, is that we've also encouraged and empowered the persons in retail, in food establishments, etc., to deny entry to persons who don't wear masks to come into the establishments. And I've seen that actually fairly universally across the parts of Trinidad that I've gone to. No mask, no service. Please wear your mask to enter, etc. And that, along with the near ubiquitous hand washing stations everywhere, which I honestly hope we keep forever. Those things are really going to add, because it's multi-layer protection. Hand washing, super important. The hygiene and taking off and putting on the mask, super important. Wearing masks when you can't physical distance, for example, when you go into an establishment, super important. And encouraging the establishment owners to enforce that. That seems to be working as well. So again, it's layers of protection that we're putting on, hoping to normalize all of the good behaviors in advance of increasing any risk of importation.
So just to add my wholesale endorsement of what's been expressed. So I think there is something powerful about normalizing a behavior, recognizing that it's new to all of us. COVID-19 has only been around, detected since the end of December last year. So it really has just been a short period of time. But I would encourage the viewing public to think of your face covering. So you keep it when you're leaving the house, you pick up your wallet, your bag, your keys, and your mask, and you go down the road with your mask. So it's something about being accustomed to wearing it and taking that wholesale approach. And just to quickly pick up on something Dr. Boisson said about how powerful it is to think of the interventions we have to protect ourselves against COVID-19 as a package of interventions, right? The other thing I would encourage people to do is if you have any symptoms of any kind of respiratory virus, so if you're sneezing, you're coughing, you have a fever, stay at home. So I can't stress that enough. If you do take that step, bearing in mind what's been mentioned earlier, that you're more likely to spread the virus if you are symptomatic, you're really, really going to, I think it's in the public interest, honestly, to ensure that you look after yourself, you look after others. And if you have those symptoms, you stay home. The majority of us will not have symptoms, will be out and about. And again, it's about the public health interventions already discussed. So the hand hygiene, the respiratory hygiene, face coverings when you can't physically distance.
Thank you all so very much for those brilliant and important points, very critical points. I think we are definitely enlightening our viewers with this information that we are presenting them. Time to change gears a little bit. We could all agree that the understanding of COVID-19 is rapidly changing. And while we are seeing that the global numbers of confirmed cases are well over 13 million, and the number of deaths, even though over 0.5 million, is now beginning to tail off, doctors are saying that this COVID-19 virus is very unique. It's very different from most viruses that they've seen. Dr. Bissau mentioned earlier that immunity after infection appears to be fading. So we are learning that persons who already had COVID-19 could get a second infection. COVID-19 is now believed to increase clotting factors, which could lead to microthrombi and also lead to increased ischemic stroke. The ventilator hype was quelled recently when doctors learned that proning patients from time to time could actually increase oxygenating. The interest with regards to hydroxychloroquine was shifted to dexamethasone. Earlier this week, we had, the big game changer, which is like the new fresh topic out there, vaccines. And while we have about 21 countries currently rapidly working on trials, Dr. Elena Smolyachuk of the Sechenov University in Russia completed clinical trials indicating that this vaccine is looking very positive. And on Wednesday of this week, Minister Dialsing announced that Trinidad and Tobago will be one of the countries in the Pan American Health Organization to be negotiating the potential use of these new vaccines whenever they become available. So it appears that we already have an action plan in place once a vaccine becomes available. So the question is now, given that we actually are able to obtain a working vaccine globally, how soon will we see these numbers beginning to change?
Well, maybe I can kickstart. I wouldn't want to say soon. We're still in the trial stage. Vaccines take a while before you can have them out there. They have to go through several layers of clinical trials to ensure, one, that it works, and two, that it's safe. We have been successful, for example, with getting a vaccine for H1N1 quickly, but we had vaccine for different types of flu before that. On the other end of the spectrum, we've not been successful for getting vaccines for some other viruses like dengue and HIV, which that has been sought after for many years. There's been a lot of development of vaccines. We got pretty close to one for dengue, and then it was found not to be safe. So there's still some time yet, and we can't jump the gun and say that it's going to be soon. We hope, but we don't know. Whenever we do have a vaccine, we will also have to consider, not everybody's going to be able to get it at once. You're going to have to mass produce that vaccine. So this is why we have an agreement, global agreement, whereby countries who would like to buy in to being part of the countries to receive the vaccine as soon as it's available, and part of that group of countries who are willing to contribute to assisting with in whatever way they can, whether it's financially, whatever, mass producing. Some will be able to do that, some will not be able to do that, but mass producing not just for themselves, but globally will buy into that. And Trinidad has committed to that, and more countries are doing that. Of course, it's in everybody's interest, because until we get it under control everywhere, nobody is safe. What countries have been doing, and I would just add that all countries in the Americas, including Trinidad and Tobago, long before this, long before H1N1, had influenza pandemic preparedness plans. Because since we've seen avian influenza popping up now and then, we've been anticipating there may be an influenza pandemic. Well, it turned out it was coronavirus, not influenza. But these influenza pandemic preparedness plans were very quickly adapted and in the Caribbean, very quickly implemented. Part of those plans would have looked at when a vaccine becomes available, how will you distribute it? And it looks at distributing to your most vulnerable first and so forth. And countries have adapted their influenza plans. Trinidad and Tobago certainly has, and all the other Caribbean countries. And so they already know when a vaccine becomes available, who will be those persons who get it first? Who are your vulnerable populations? Your healthcare workers, those who are older, those who have those underlying conditions that put them more at risk. They will be the first ones as the first batches come out, and then others will be able to get the vaccine later on. But it's not something that's going to happen today or tomorrow. We hope sooner rather than later, but it really is still, while promising, it's still in the early stages. Over.
Thank you very much, Dr. Wassau. And I think we were really interested to know that particular piece of information, considering what came out. Dr. Rogers, I just want to bump in here. There are two questions that came in from the general public. The first question, really, I think Dr. Wassau, you can answer this one, considering you continuing. This is from Enterprise. They wanted to know, with the soaring rate recording in the USA, and assuming that some cases are not recorded as well, what has the mortality rate decreased to, and when will herd immunity be achieved? People are curious about that.
So right now in the US, the mortality rate is just under 4%, 3.9%, even though they have had the most cases. They've had about half the cases in the Americas, but it's about 4%. In terms of herd immunity, even though they have had about 3 million or so cases, the population of the USA is huge. So right now they've still only had a very small percentage of their population infected. In terms of herd immunity, we don't know what it is for COVID-19 because it's new. But I can tell you certainly the vaccine preventable diseases like your measles, mumps, rubella, and those ones that you get vaccinated for, we're talking more than 90% is what you need for herd immunity. We do that artificially because we vaccinate, so people don't have to get the disease to get immune. We vaccinate them. So to get to herd immunity is going to take quite some time. First of all, one, we don't know what percentage herd immunity is, but based on other diseases, it's going to be a lot more than what they currently have. And the question will be, is if they have to get to herd immunity, will they have enough capacity in their healthcare system to deal with all the severe illness that you will get as a portion of the persons who have to become ill? And so this is why countries have really been, some initially tried it for a short time and quickly their systems became overwhelmed. And so that idea of trying to get herd immunity has been somewhat shifting, because in doing so, they are getting too many severe illnesses, too many deaths, and not just to COVID, because when you overwhelm your health system, it means persons who are ill with other diseases cannot get the care that they need. So your mortality goes up, not just due to COVID, but to all sorts of other things. Diseases, both communicable and non-communicable, injuries, violence, pregnant women, all those things will go up as well. So we don't know about herd immunity, but if we were to wait on that, that will be quite some time, and not just some time, but following quite a lot of death and illness. So I don't think generally that is what we're aiming for. Over.
I'd just like to jump in here and add to what Dr. Watson was saying. So the herd immunity concept, the herd immunity question, I hope that the takeaway from what was just said is that that's not what we're looking for. It's not one of the metrics that we're even hoping to try to accomplish in the near future with regard to preventing spread. All of the other things that we have been talking about in terms of preventive measures are going to be a lot more valuable. Herd immunity, as you just heard, requires large numbers of people to become ill. And in large numbers of people becoming ill, you're going to end up with overwhelmed health systems and with a lot of excess mortality, people dying because they couldn't access healthcare in the way that they should. Additionally, there are going to be queries around whether you really can achieve herd immunity for this particular virus, given the fact that immune status doesn't seem to remain permanent. You don't seem to remain in a permanent state of immune protection. We're not even sure how long immunity lasts after the initial infection, and all of those things are factored into how you work out what proportion of your population may need to be infected for herd immunity. The other thing that factors in there is how many people get infected per individual case, and that's variable at this point in time. It depends on the kind of exposure, the proximity of people. So that herd immunity question and calculation, there are too many undefined or poorly defined variables around that for that to be a focus. I know we've been hearing it internationally, and I am quite happy to add to Dr. Boisson's perspective that herd immunity is not where we're looking right now. It's probably not what we should be looking at, and all of the other measures that we can put in place before are going to be a lot more valuable. Over.
So I completely agree with what's been expressed by my fellow panelists, and just to say that the only measure of herd immunity we'd hope to see is vaccine-acquired herd immunity when the vaccine is available, and that is, we're going to have to wait for the vaccine. So it is about implementing and adhering to the existing public health guidance to reduce the risk of transmission. So it's definitely about reducing the spread within the community and ensuring that we keep the numbers low and we do not overwhelm the health system.
I'd like to say thank you all to our panelists and to our viewers. Unfortunately, we are nearing the last few minutes of this webinar. And in doing so, I would just like to make a few salient summary points before I hand over to Dr. Rambaran for his vote of thanks to our panelists and to our viewers. We've highlighted some very, very critical points during this discussion. We've discussed some points related to trends, and we now have a better understanding of the numbers that are appearing in the UK, in the Caribbean, and in Trinidad and Tobago. We have discussed tests and the validity of tests. We've discussed that positive tests could also hide negative tests as well. So it could actually having a test and showing that you're negative is not necessarily stating that you are totally free of COVID. You may be a false negative as well, or false positive. We've discussed masks, and we have a better understanding of the manner in which a person should actually treat and wear a mask. There are protocols to guide them. There are different types of masks, and they're not all equal. We have discussed borders and border control and spread with regards to reopening borders. So I hope that this discussion actually provided the public with some very, very important information as to, how they understand what the governments and the administrators are doing in order to reopen borders. Some people are very eager, but in reopening borders, we have some dangers. And the best thing to do is to follow the guidance of the authorities. We have just quickly discussed vaccines, and that is the new wave. And what the advice coming out is that we need to be patient. We're not going to see a sudden change in numbers. There may be a little bit of prejudice as to some people who would want to actually take the vaccine. And we've just wrapped up a short discussion on herd immunity. We would love to do a lot more questions and spend more time, but unfortunately, our panels are very, very important, very busy people, and they can only afford us a limited time, perhaps maybe in the future. But what we will continue to ask you to do is to email in your questions, and perhaps we could still provide some answers if you email your questions. I now hand you over to Dr. Rambaran for some vote of thanks.
Thank you very much, Dr. Rogers. Ladies and gentlemen, in closing, I'd like to thank the members of the viewing public for logging in and participating in this interactive and very informative event on how best we can cope with, or coexist, with COVID-19. I strongly believe that we have learned a lot from this webinar, and we at UTT continue to do our part in assisting our country to overcome this very unfortunate situation that has hit the world so terribly. I would once again like to thank our panelists, Dr. Hines, Dr. Mohammed, and Dr. Vaso, for taking their time from their busy schedules to be part of this roundtable discussion, this virtual roundtable discussion. And I wish you all the best, and I hope that you continue making positive strides in the field of medicine and research. Take care, and thank you all.
Thank you very much.
Thanks, everyone.
Okay, thank you and goodbye.